it's the experience of migration that is key to the health and
All right, good evening to all of us, and thank you so much for joining. My name is James. I'm the General Secretary for GPHA. As we start this session, I'll hand over to Abena Ochu, who is our moderator for today, to start the meeting. So over to Abena. Thank you very much.
Okay, thank you very much, James. I would like to once again say a very big thank you to all of you, members of the Ghana Public Health Association, for honoring our invitation to attend this scientific session. All the others who have joined, partners, collaborators in all diverse organizations, Ghana Health Service, UNFPA, the Christian Health Association of Ghana, and all that we can't mention, our friends and other related people in the various communities of practice. I'm grateful to have you all this evening. We are going to have quite an engaging business through this session, presenting in the front of potential clients who actually sound like difficult, but I think we've had a preview of what all the lessons that we are going to focus on and how all these have been over the years. So this evening we are just having a talk, or better still, a session on the influx of refugees and health-related challenges in the camps and in the communities in Ghana, and how it has been shaped and the approach and the stress that we've gone through in and out. So without much ado, I will proceed to the agenda. So for the agenda this evening, we'll first have our open prayer, just as usual, just as any other related program, and then our introduction from the president of the association, the introduction of speakers, questions and answers, basically our recommendations and various inputs to the discussion, any other related businesses, then our closing remarks, then our closing prayer. So they are all just going to be brief. So without wasting my time, I will first invite Ms. Wilhelmina A. Okwabi to give us our opening prayer for this session. So Wilhelmina,
Our Heavenly Father, we thank you for such moments where we come together, Lord, to think about humanity and what we go through in life. We pray that this session, Lord, will be enriching, engaging, and at the end of the day, Lord, through what we discuss, recommendations we make, we give glory to your name. Be with us and be our guide. We pray through Jesus Christ, your Son, our Savior. Amen. Amen.
Thank you so much.
Amen.
Amen.
Yeah. Okay. So second on the list, I would like to invite the president of the Ghana Public Health Association, Dr. Erasmus Emmanuel Akrugu Agongo, to give us a brief introduction for this particular evening.
All right, thank you very much. I can't see Dr. Agongo on call, but I will say something briefly as the General Secretary of the Association. First of all, to thank you so much for joining us for this meeting. For us, as an association, we are a non-profit organization that has been formed with the objective of championing the public health of Ghana. And for us, since 2014, when it was properly organized, we engage in so many activities, including this webinars, writing communique, influencing policy, mentoring many young public practitioners to become very good ones in this country and beyond. We have a national headquarters, which is found in Accra, and we're in the same building as the National Malaria Elimination Program. And for those who have joined us, we have a WhatsApp platform and other social media platforms. To be a member, we have a form that we will share. I'll share the link on the chat. You can quickly fill the online form, and then you can join us to become a member with just an annual dues of 240 cedis. We encourage all of us who are joining us today to be part of that session. There's a lot more we have for you going forward, but this is one of our regular programs that we do to share knowledge, to see how we can help influence policy in this country, so that we can get ourselves well prepared for the public health issues that we found in this country. So thanks so much for coming. And on behalf of Dr. Gongo, as our president, and on my personal behalf, I want to welcome all of you to this meeting. I pray that we have a very good session this evening. Thank you very much. And over to Abner. Thank you.
Okay, thank you very much, James. Okay, so I think to all our participants this evening, just as James has said, in an observation, if there's anything that's any inputs or recommendations, or any other related, you can as well put it in the chat box, which I'll be visiting quite frequently in order to make things easy. You can also keep a diary similarly, so that when it's time for questions to be answered, you can as well voice out all that you have in terms of comments in view of this particular session. Okay, so I would like to invite our Public Relations Officer, Ms. Irabna Dazi, to introduce our speakers for this evening's session.
Yes, thank you so much, our General Secretary, who spoke on behalf of our President, and thank you so much, Abner, for leading us. Good evening, ladies and gentlemen. I'm highly honored to introduce to you our key personalities who will be sharing with us on behalf of the executives of the Public Health Association and on behalf of the Scientific Committee, whom I'm humbly to chair, that have led in putting this together. We'd like to share with you our speakers for this evening event. I am highly honored to introduce to you Dr. Divine Atupra, and he's a very noble man. Some of us have met in him during our duties, and today he's going to share with us some insights on the topic that we have shared. So who is Dr. Divine Atupra? He's such a wonderful and a noble gentleman, and his full name is Dr. Divine Kojo Atupra. He's a trained medical doctor with over 20 years of clinical and public health experience. He is specialized in public health physician and also a subspecialty in family health medicine. He has a strong passion for maternal and child health and has been working all these years to improve the quality of birth outcome and reproductive life for women. He is currently the fund manager of UNFPA flagship program of maternal health thematic fund, and also the humanitarian point person of UNFPA. And he represents UNFPA on the Interagency Working Group of Emergencies. He also does strategic analysis, planning and implementing of UNFPA, MNCH, prenatal death, surveillance, response, emergency, obstetric fistula, and also obstetric MNC. He has worked as a consultant with UNAIDS to advise on Ghana and has advised Ghana AIDS Commission on modalities of accelerating HIV prevention program. He has also worked on several USAID funded programs, and he has served on USAID programs at the technical level and also managing complex public health projects in SRH, adolescent health, family planning in Ghana. Throughout his career, Dr. Atupra has managed and supervised health teams and program officers for projects reaching over $70 million. Family planning and cervical cancer, breast cancer has been one of his main areas, and he's been an advocate, and he's also a renowned marriage counselor. As a strong maternal and child health advocate, he has successfully led a liaison donors IPs of MOH and Ghana Health Service private sector to ensure improved quality reproductive health for women, adolescent girls, and general populace. Mr. Divine possesses an exceptional skill, and of course, I have known him for some time now, and these skills can be very eminent in how he's very innovative in supporting women, also developing new concepts, also his deep dive into obstetric fistula repairs and ensuring that communities have the good space of life when it comes to maternal health. He's also has proven track in analytical thinking, and he's robust in leadership. And after dedicating 8 years of his field of sexual and reproductive health, he has gained deep understanding into the challenges, opportunities, and gaps. And so, firmly, I believe that he provides this role, and he does collaboratively with his partners. Aren't we very lucky this evening as Public Health Association members to have such a wonderful person share with us this evening? We can use our reactions to give him a big clap as colleague Abna would be inviting him to share all the wisdom and the knowledge that he has with us. Thank you all for the clap emoji, and Mr. Divine, we are really proud and we are highly glad to have you on this call to share with us your dynamic experience and also the impactful work that you have done in Ghana over the years. I would like Mr. Divine to maybe open the camera and we can give him a wave. And yes, so he's here. Welcome, sir. We are highly honored to have you. We are so humbled and great to have you. Thank you so much for making time to join us this evening. And I share with you another noble man, and he's been my boss since when I was 20s and I started my career. And he, at a point in time, was the only surgeon in the Kintampo Municipal Hospital. And so when it comes to CS, he's been called when it comes to any event, and he was really a gem that we can boast of. And so without much ado, I'll introduce to you another wonderful man who is Dr. Damien Pungiri. He's currently the Regional Director of Health Services for the Upper West Region. And Dr. Damien is a public health practitioner. Doc, please forgive me. I can't change Doc to Mr. Dr. Damien is a public health practitioner with interest in communicable disease surveillance, preparedness, and response to public health emergencies, reproductive and child health, monitoring and evaluation, and developing programs for data collection and analysis. He's a medical doctor with 17 years. I said Dr. Divine has 20 years. Dr. Damien has 17 years. Wow. Experience spanning through clinical work, project management, research, disease surveillance, preparedness and response, undergraduate training, and leadership. His major career objectives is to develop a full potential and to rise up to the top of career through hard work and determination, which he has done so well. To also build excellent personality that would enable him to work diligently and effectively, which he has done so well, and also to develop positive attitude, which he has also done so well and impacted in a lot of health workers. As a regional director of Ghana Health Service in the Upper West region, where he led over 4,500 persons in his team, he implements, monitors policies and programs, including public health surveillance and reproductive health services. Prior to his work as a director, he worked with the district health of Nkranza, Techiman municipalities, and also Kintampo municipality as the medical superintendent. And he has also worked on special appointment service of epidemiologists at WHO country office to support Ghana to build capacity of disease surveillance, response, and reporting to data disease outbreaks of epidemic diseases, such as meningitis, cholera events, outbreak, in accordance with international health regulations, and support country efforts in public health emergency preparedness. He has some major accomplishments, and one of that is that he has been a leader of the investigation team that investigated the circulating vaccine-derived polio virus type 2 outbreaks in the German North in the Bono, Isutifi, and Techiman. He also successfully evaluated the human rabies and dog bite surveillance systems in Techiman. He also evaluated and implemented measles surveillance, and he also guided the municipal to achieve Penta-3 coverage to 98% in 2016 to 2018. Wow. He has also successfully established functional community health planning services zones in 35 electoral areas in Techiman, which brought health service to the community levels with full participation of community stakeholders. If I want to read everything of his success, we might not end the session, but I would move to his academic qualifications, and please will be sharing some key highlights of him as the discussion goes on. Of his education ladder, he has a BSc Human Biology, he has Medicine and Surgery with the University of Ghana College of Health. He also had Health Administration Management with GIMPA. He also has Tropical Medicine Hygiene. He also has Management and Administration. He also has Public Health Epidemiology, which is an MPH. He has Leadership Management certificates. Please, yes, this is really a noble man, and I can't share all. And so as he leads the presentation, we'll continue to share aspects. So once again, let's use our reaction to give Dr. Damien a round of applause for how far he's come in his wonderful achievements. Dr. Damien, if you can show your video for us to see you and for us to, yes. So this is the man, Dr. Damien. We are highly grateful and honored to have you on this call and to share with us your in-depth knowledge as has been shared in your profile. Thank you so much for the opportunity granted me to introduce this highly honored personalities to you. Very grateful. And over to you, Abna. Thank you.
Okay, thank you very much, Madam. It's time for our presentation. It's time for our presentation, and each of our speakers have 40 minutes. To present, to give us their various views, and all, and how the journeys significantly have been. Just as we know, Ghana on several accounts, in creating an engaging business, has a history of hosting refugees from neighboring countries due to conflicts, political instabilities, and environmental factors. But the recent surge in the numbers of refugees has strained the existing health infrastructure and resources. But ensuring that health and well-being of both host communities and refugees is paramount. It's all important, and government of Ghana implement strategies to improve the public health. So this is the cause of our discussion. The influx of refugees into Ghana posing significant challenges, and particularly in the realms of public health. There are so many dimensions within the nature of this particular engagement, but I think it will be well handled by both present speakers for this evening. So I will first like to invite Dr. Divine Atupra to give us his presentation. If a presentation, some slides have been, or if there's anything, I think Mr. Dr. Atupra, please, I would, the floor is yours to, the whole house is ready to hear from you. So.
Okay, thank you very much. I hope you can hear me.
Yes, I can hear you. I can hear you.
Yes, we
Thank you.
can hear you. Divine,
Yes,
welcome.
please.
Thank you very much. I'm humbled, Rabna, for the introduction that you're giving me. I must say that, I mean, I prefer to be called Divine because that's what I'm known for. All that you said, fine, thank you very much. But then I believe that, I mean, women should not die in the course of, I mean, producing other humans, which we are. And then I believe that God has given us enough knowledge and abilities and the capabilities to be able to stop some of these deaths. And that is why we call them unnecessary deaths, or we call them deaths that we can eliminate. That is why my passion to drive the health of women and then girls, for that matter, is so strong. But then, thank you for the invitation today. I was asked to speak a little bit about what we are doing in the area of humanitarian crisis in Ghana. As a matter of fact, as a country, we know that we are a country that a lot of us consider as a haven as far as the other West African countries are concerned, because of the peace that we have, as compared to countries like Burkina Faso, Mali, Togo, and part of northern Nigeria. And because of the terrorist activities over there, there's so much challenge that we have in these areas. And so there's quite a number of women in particular, over 80% of them being women and girls and children, are trooping into Ghana through the northern border. And so really it is a challenge. Ghana as a country has to know that despite the fact that we are a safe haven, gradually this peace that we profess is gradually eroding, because this group of people that are coming in, or the general environment, as far as, I mean, the West Africa sub-region, the Sahel is concerned, is not safe. And so we really have to be thinking. But let me say that for Ghana as a country, there are five main what do you call it, risk or hazard that we talked about when we talk about humanitarian, that brings about humanitarian challenges. The first one has to do with conflicts, which I just mentioned briefly. The second one has to do with floods. The third one is tidal waves that occurs in the coastal belt of our country, especially in the eastern part of the Ghana, eastern coast of Ghana, and then also earthquake, and then epidemics of infectious diseases. These are the main hazards that actually sometimes shakes, or let me use the right word, shakes our country and then creates a lot of a disturbance in our country. When we come to conflict there, but we talk of the internal and the external one. In the northern part of Ghana, we know we have quite a number of internal conflict as a result of chieftaincy issues, ethnic conflicts, and then or ethnic and conflict with ethnic undertones, and then also land. I mean, people, I mean, are identified by two main things: where they are born, the land that they occupy, and then the name that they give to themselves. And so, I mean, people all over the world, I mean, fight for lands in order to acquire lands. But I mean, I think, I mean, we've gotten to a stage in our world where lands are supposed to be well demarcated and belong to people, but we still do not have that in our country. And so there's so much challenge with issues of land in Ghana. Then when it comes to the external conflicts, we, as I said, there's quite a lot of challenge with the Sahel region, and we are not very certain what really is going on, because in the recent past, as of August, I think 30th of August, we had over 15,000, asylum seekers that actually crossed the border of Ghana, and then seeking asylum in Ghana. The interesting thing is that most of them comes in and they prefer to stay in the communities, but then they refuse to go to stay at these specific areas that we have actually designated for them. The laws of Ghana actually give the power to only the Minister of Interior to designate, specific areas or camps that can be called refugee camps. And I think so far we have two in the north, one in Tarikum, I think that is the Boku West region, and the other one in Zini or Sisala West region. We have challenge of these asylum seekers agreeing to go to this, to stay in these areas, to have themselves registered, because they cannot be, as far as our laws are concerned, they cannot be registered in the town. For them to remain in the town, they must go to the refugee camps. And so it's a challenge. But then I think Ghana Refugee Board, the United Nations High Commissioner for Refugee, IOM, that is the International Organization for Migration, UNFPA and all that, we've been doing quite a good work trying to, as much as possible, to see how best we could address these issues and have a lot of them, stay in the refugee camps. Now, the challenge with Ghana, or the government of Ghana, and for that matter, is because of especially the security agents of Ghana, is that, it's dangerous to have these asylum seekers to be staying near the border towns, because you don't know exactly who they are, whether they are actually people who are actually fomenting troubles. Are they dissidents? Are they the people who are radicalized and coming to radicalize some of our decisions? We don't know. And that is why, it makes a lot of sense that they should put them at a place that they will not be too close to the border. So, hello. Yeah, so that is that. Then we come to the floods, and we do have quite a number of challenges with floods. We know last year, 2023, we had quite a number of these floods. Now, we know that some of these hazards are natural hazards, but then human activities has caused a lot of them, has created or has enabled a lot of them to be a lot more rampant than we expected. And so we've been having quite a number of these hazards. 2023, we had a severe rainfall that was in the sub-region, the West Africa sub-region. And so we had a lot of spillover from Burkina Faso and then also in Ghana. And so our dam, whether it is managed well or no, I don't know. But somewhere along the line, we have to spill of the water, and that actually subsumed a lot of communities. We had about Volta region, almost about 5 or so districts with a large percentage of their communities being submerged in underwater. And I'm sure all of you saw the pictures. It took a while for them for the water to recede. Quite a number of them had places to stay, what we call the safe havens. And I know that the North Town, they still have about 5 safe havens that contains about 1,000. People living there because their homes are completely destroyed and they cannot move in. So that is about a flood. Now, as I said, a lot of activities which I would call man-made disasters are actually
because we can't see your screen.
No, unfortunately, I'm not projecting.
All right. Okay. Thank you for that.
Sorry, I'm not projecting. I actually have not had enough time to. I'm not projecting. Sorry, I can. So that is what is about this. And then another very important, challenge that we have, which we need to talk about, is the challenge of tidal waves. Tidal waves has also actually been a problem in the Volta region, and it's been creating a lot of a problem there where a lot of communities get subsumed underwater when the waves are very high. And then all this is as a result of global warming, which we are all aware of. And that is why, as a country, we need to take very drastic measures that can help us, improve, the issue of globalization so that the amount of carbon that we release into the atmosphere is decreased. We also have earthquake, and in Ghana, we know that the Ghana may not be too close to the major earthquake zones of the world, even though it has experienced a number of earthquake disasters. And I would say that Ghana has an evidence of disastrous earthquakes dating back to somewhere 17th century. And these, the last 3, major ones occurred in 1962. Then the one that followed that was 1906, and then the 1981. These are the recent. And the highest that we've had in Ghana was rated at about 6.6 Richter scale, which is quite significant. And then that was in 1939, which caused a lot of havoc in the country. And the last major one that we saw was something that happened in 1997, which was around 4. I think that I was also quite old then, so I witnessed, and I believe quite a number of us here witnessed. So that is another challenge that we need to be thinking of how to manage in terms of the infrastructure that we develop, buildings and all that, where we develop our distance, the minor earthquake, what do you call it, zone lines that we have, we need to know how to manage in such a way that our buildings are not actually on that. Then the last but not the least, the infectious epidemics, that is the hemorrhage, and then the hemorrhagic fevers. We are aware of the mpox. That is quite a challenge in the country now. We have quite a significant number of people that are positive, and that has been. I do not have the direct figure for you. I know that you are all, privy to the regular, almost weekly update that we do get from WHO. I could send some of those to those who may not have it, but it's quite a significant thing that we need to be concerned about. And I believe that the Department of Public Health or the Division of Public Health and the Ghana Health Service is really working hard at it. And so that is one of the things. The other thing that is also well documented is that, some of our conditions that we do have in the past, like the cholera outbreak that we've not had for a long time. I heard we had something that's similar, something that looks like an outbreak in the Volta region, part of Volta region, which was actually managed quickly. And so
Right,
it is-
Chaka. Yeah, it's not following.
Hello.
Sir, please, you are on. You are on.
Can I
Yeah.
go? Okay.
Yes,
So-
please, you can continue.
Yeah, so and that was a challenge over there. So now let me come to you, NFPA, that I work with now as a consultant, so that I let you know exactly what we do. Now we provide protection in the sexual and reproductive health, maternal, newborn, and child health, family planning, GBV, and other harmful practices. To all those who have these challenges, how do we do it? We actually do regular, work with Ghana Refugee Board, we work with UNHCR, we work with the NADMO, just to be sure of the navigate the data, and then we support some IPs that can provide some of these services to them, and the rest to health service. One of the key things that we are very particular about is the dignity of women. Crisis. Women still go through their reproductive cycle, and so we want them to have that dignified life, and so we provide them what we call the dignity kits. Which has different types and content, has different contents depending on who you are, whether you are a teenager, you are adolescent, you are a pregnant woman, you are a nursing mother, and then an old person, or maybe you are a disabled person. We have our medicine that we give them. Then we collaborate with the Minister of Health, Ghana Health Service, and NADMO, and then all the key stakeholders to conduct a minimum initial service package. Now, what does this mean? Ghana need to really know exactly how prepared we are to manage crisis when it happens. And then so UNFPA does have what we call the MISP, or that is the minimum initial service package, which we expect every facility to be able to have to be able to manage sexual and reproductive health issues during crisis. And so what we did first was to bring all the stakeholders together, and then hire one of our own professors that I think to really do the assessment first, to look at what is it that we have, what sort of preparation that we have, what sort of plans that we have, and then we look at all that. We first have to identify who leads the process, and we identified the Ghana Health Service Minister of Health to lead the process with support from NADMO, and then we actually take the minimum initial service rapid assessment, and then developed an action plan which was validated with key stakeholders. But then afterwards, we actually have been making some resources available to the Minister of Ghana Health Service, to implement some of the issues that we identified during the assessment. I think last 2 weeks we had such a type of training in one of the districts that is seriously hit. That is North Town district, and where we have built capacity of the whole district to be able to be more resistant or more resilient. That's a better word. During crisis, may happen again. And so how to manage it, how to coordinate it. It is more of a coordination distance. And out of that, another very innovative thing that the UNFPA decided to do is to develop what we called humanitarian emergency register. Basically, what it means is that we have identified through the Ghana Health Service Minister of all key professionals that will provide the necessary sexual and reproductive health services, and then HIV services, family planning services, gender-based violence services, and all those services that will be needed during crisis. And so we took them through, we developed their capacity in how to plan during the emergencies, how to be able to mobilize themselves quickly, and then some of them are able to volunteer themselves onto the register. When you volunteer yourself on the register, which is kept by the Ghana Health Service, then when there is a crisis, the district, and for that matter, the Ghana Health Service hierarchy can invoke that list, and then call you, and then you have to respond, except that you have any very special reasons or maybe sickness or anything else. I mean, you may have to respond to that. You can help us. I mean, keep people alive, and then stop the hurt that people go through during crisis. And so that had been done for Volta region. We did the same thing also. Actually, we selected regions that have prone to this conflict, and for that matter, crisis. So we selected upper west and then upper east region also. For upper west and upper west and upper east region, we selected all the districts that borders with Burkina Faso. So these districts were actually brought on board, and we trained them all out to be very ready how to manage crisis, and then coordinate and manage crisis. Of course, UNFPA is working towards providing resources for them to be able to do that. Let me do this in quickly. Then funding, and then supervision of IPs, that is implementing partners, that some of them are NGOs. We provide resource for them that they can help during this crisis. Example was what we did for Volta region when they had a problem, and we had to
Hello, sir. Okay. Okay, I think Dr. Divine will join back. I can see him on, but there may can be network problems. So let's wait for just some few minutes for him to join back.
Please, can you hear me now?
Yes, please. I can.
I think it was a mistake.
Okay.
The other one has to do with what we call the pre-positioning of kits and other things that will be needed during emergency. So what we do is that we project as to what we think can be a problem in the course of the year. And so we provide commodities that we pre-position at some specific spots, in our country, that when there's a need, we quickly deploy them. And that's what we did in Volta region when there was a problem. So that has been done. We also have, because of the challenge that we have, UNFPA, and for that matter, UN has actually designated some countries as humanitarian countries. And for now, Ghana is not one of those humanitarian countries, but most of the countries that surround us in the Sahel region, in the northern part, Nigeria, Mali, Burkina Faso, Niger, Chad, all of them are designated as a humanitarian country because of the challenges that are the level of displacement, the level of crisis that the human is. And the other thing we have to know is that now the crisis that normally happen to us, that's a community or a country, there's so much that you if the crisis actually is beyond the management of that organization or that country, and then becomes a challenge. That is why countries like US, who have a lot of capacity, every now and then we do have these hurricanes and typhoons in those countries, but really they are fine because they have the very huge capacity to be able to manage it, and so they really do not have problem. These countries that I mentioned in West Africa or the Sahel region, they are countries that are quite low in terms of the human development, and so they have a lot of challenge with these crises. So Ghana is not classified as that, but what we decided to do is for the interagency working group, that is UN organization, decided to form what we call the interagency working group against emergency. And so what we do is that we plan towards emergencies, and I can say that even this preparation towards the election 2024, we have started doing quite a lot of work in that area. We have done some simulations as to what happens when this happens in terms of who can we call on, what do we have, and all that. And so that's interagency working group, that UN interagency working group, has actually developed what we call a contingency plan to help, the agencies to be able to work. But apart from that, UNFP has developed its own contingency plan to identify specific things that we need to do. We have actually submitted it to our headquarters. It's not been approved yet. When it's approved, then we can share it. So AXA now I cannot share it because it is yet to be approved. So basically, those are the things that we do. Basically, those are the things that we do as an organization. And so I would end here, and then if there's any questions, I would answer. But I want to say hello to some of my my bosses, my professors. I saw Prof. Tupri and others on board, and I want to say good evening to all of you. Thank you, and over.
Okay, thank you very much, sir. Thank you very much, sir. We have a session for questions and answers. So during that session, we will take care of all the other related questions, unless otherwise you would like to leave us. Okay.
No, I didn't get your question. I didn't get your concern well.
Okay. I said on our schedule we have an aspect for Q&A, that's the questions and answers.
Yes.
So I would like you to rest for some time. Then
That's fine.
Yeah.
That's fine.
Yeah.
That's fine. Thank you.
We go into the next person.
Thanks.
Okay. So I would like to invite our next speaker for this evening's session to our speaker for he is in the person of Dr. Damien Apungu. Sir, please pardon me if I didn't mention your name well. He is the Upper West Regional Director of Health Services.
Hello.
Hello,
Hello.
sir.
Good evening, sir.
Good evening. Good
Yes.
evening. Please, we are ready for your session. And so you
Good.
can
Good
take over, sir.
Yes, so let me say good evening to senior colleagues and colleagues alike. My thoughts on this topic, I want to share with you on this topic, influx of asylum seekers into northern Ghana and its implication for public health. And I'm sharing the experiences from the Upper West region. I know northern Ghana is big. Upper East has influx of immigrant population, Savannah, and the rest. But because of difficulty in getting data from these districts, these regions, I have decided to share this, our experiences in Upper West, believing that since these regions are similar in characteristics, it's likely to reflect. And so in this presentation, I'll just give you a brief background, and we'll look at the vulnerability profile of the Upper West region. And then we'll look at findings from a survey that we did, because when the numbers started increasing, we need to estimate the population of immigrants in the region, so that this will help us to plan resources to be able to meet the increasing demand. And the support we have provided so far, we'll look at the effects of this extra population on the health system in general in the region, and of course on the refugees population, and definitely also the effect on the host population. And I attempt to propose strategies to address. I know this will be a focal point for discussion, so I'll attempt to propose some solution that I think we need to take certain actions to address the challenges were identified, and then I'll bring my presentation to conclusion and one recommendation. So largely, the Upper West region shares borders with the Burkina Faso. Our northern part of the region is sharing border with Burkina Faso, and it's largely unregulated because there are several points of entry to and through Burkina Faso. Though we have 2 designated ports of entry, people are able to move in and out without being noticed. And generally, because the tribes across the borders, there are relations. There has been a baseline transborder movement of people, goods, and services over the years. And this has never caused any significant shift in demand for the services. However, we noticed that due to the political instability in the Sahel region, many immigrants have now joined the region. They've established settlements adjacent to known communities, and there are some isolated, some are in the bushes by themselves, and then few have been moved to a refugee camp. So we have noticed that this has exerted a lot of stress on the health system because we have limited resources, infrastructure, and commodities. We know that how we plan our public health services is, especially for vaccination and other services, based on unit population. We had already conducted our 2020 population and housing census. So the region's population is known. Anytime resources are being delivered, it is based on that population. And now with this extra population that has come, each time we send resources to these districts, within a very few days, they get finished. And so with support from UNICEF, I wanted to actually find out what the numbers are, especially across the 2 dominant Sisala districts, that's the Far East districts, where most of these immigrant populations come to settle. So the region generally, is shedding is situated in the northwestern part of Ghana. The population is nearly 1 million, and this population is distributed in 11 administrative districts. And I mentioned that it is bordered to the north by the Burkina Faso country. The western part runs through by the Black Volta that forms a natural boundary to the region, and the Savannah region to the south, and Upper East to the west. And so when you look at the population density as per the land size that we have, it's so sparse and ranges from 17 persons per square kilometer to 363 square kilometer in Sisala, East, and Ward municipalities, respectively. But we also notice an increasing phenomenon of Fulani herdsmen who move in and out of the region from Burkina and Niger. And that has been a phenomenon. Each time they settle, you want to send services to them, then they move to another community, and it's really quite challenging to get them. Again, the predominant activity in the region, economic activity in the region, is largely farming. And because the season is very short, about 4 months rainy season, every year you have the youth traveling down south. There was like Bono East, Bono region, and the other parts. Then when it's time for farming, they come back. So they move, some also move with children in and out. And that has an implication for public health. Again, the region has been noted because of its long dry season of being a zone where meningitis outbreaks always claim lives and so on. Then we have the Galamsey. You expect that Galamsey is in the forest area, but now Galamsey too is in upper west region, where you have people moving, other nationals from neighboring countries coming to settle in these areas to do Galamsey. And the risk, as we all know, is the spread of communicable diseases, etc. Now, so this is the regional map of the upper west region, and the population density, as I mentioned. This is the population density. You can see that Sisala, 3 districts alone, the landmarks of 3 districts alone is more than the rest of the region. And those are where we have the lowest population density. Now, what it means is that because of the sparse nature of the population, health workers in these areas will have to travel long distances to be able to render services to the people. And these 2 districts, Sisala East and West, are where the refugee population settle. And this is for obvious reason. Because of the large land size, probably they will be able to go into farming and so on. This map shows the distribution of health facilities in the region. And you can see on the western side, the health facilities are quite concentrated. That's where the larger part of the population is. As you move towards the west, then you have fewer health facilities, meaning residents in the eastern part will travel on average long distances to be able to reach health centers to get the necessary care. And this is quite challenging in the region. Now, on human resources, you can see the distribution of the various cadres over the years. It was 2022 that we had the larger numbers of staff. And then since then, the number has been constantly dropping. I think what is very significant here is the community health nurses. These are the lower level cadre of staff who are found at the community level to render health promotion, disease control, prevention, getting vaccines to children. So if these numbers are keep on dropping, it's likely that the communities are getting deserted from the service. And then also, looking at the numbers of doctors, you can see that currently we have 101 doctors in the region. But the interesting thing is that almost half of them are in school. And so the few that are available to render service, if you look at the average population, doctor to patient ratio, for the 101, you have 1 doctor is to 7,500. But for what is available, you have 1 doctor now currently attending to almost 15,000 persons because of the long duration of stay. Some go to school, they don't come back. Others are in school. By the time they are coming back, they are given extension. The college now has a policy. So, for instance, last year I have 4 doctors who left, who were supposed to come. 3 were given extension to continue straight to fellowship. So they didn't come and new ones are going. So that is a challenge that the region currently faces. So because of this influx that the region was experiencing and the difficulty in getting accurate data, you ask NADMO, they don't have correct data. You ask Immigration Service, they don't have correct data. We wanted to find out, at least at that point in time, what were the numbers that we were dealing with? We didn't do this across the whole region. We know most of them were residing in 2 districts. So we decided to attempt to get information so that we'll be able to know, characterize them, and then plan the services to be able to serve their needs as well as serving our own people. So the objective really was to be able to get a detailed population characteristics of the immigrants residing in the districts, and then to be able to mobilize resources to address their specific needs and also continue to maintain services to our own people. And these are the specific objectives: to determine the exact population, and then to look at their vaccination status, determine how their presence affects our health service delivery and logistics distribution in the region. So what we did was that we had to train data collectors. Largely, we have footprint in every community because of the chips that we implement. It means that every community has at least a health worker or a volunteer, health volunteer working in these communities. So they were trained on the tool that we had to use to collect the information. And this tool was pre-tested, and then we send them out to collect the data. In addition, to be able to make sure that the people cooperate. The reasons why NADMO and Immigration Services weren't able to get accurate information is the fact that they see them as looking for them to repatriate them. And so we had to work with the community leadership, where they know where the settlement areas are. So we had this community engagement exercise to gain their confidence to be able to get the right information to take. So these are some of the settlement areas that some of them are living. So at the end of the exercise, we recorded about 16,700 migrants in just the 2 districts alone. We know that Lambousie, which is also closer, has some of them, while West has, but we don't have resources to do all that. So for these 2 districts alone, we had over 16,000 immigrants. And out of that number, the permanent ones, that is those who have settled in the communities, were almost half, and those seeking asylum because of the disturbances, they were also half. Children under 5 were in excess of 2,500, and almost 40% of them are asylum seekers. And of this number, as of August this year, only 722 of them have been relocated to the Zini refugee camp in the Sisala West District. So this is the breakdown of the various tribes making up the immigrant population. They are largely Fulbe, the Moshis, and few others from Niger areas. and the sex distribution is almost even, 50-50 for males and the females. We also look at their vaccination status and compare that to the vaccination status of the host community. And you can see that they are largely unvaccinated compared to the host community, apart from, let's say, Rota, and then for the general, the elderly population, COVID-19, the rest have been very low compared to the host community. And this means that as more numbers are coming, we are getting a cohort of unvaccinated children into our region, which is a fertile ground for disease outbreaks, which has to be looked at. So the services we have provided so far for them, we organize special vaccinations for the children, those in the camps and those that are in some of the communities that we can identify. And also working with volunteers and the community health nurses, they look at the settlement areas so that we can send public health interventions like vaccination, child welfare clinics, weighing and nutrition services. Then what we also realize is that when they are going for services in any health facilities, because of language barrier, they are unable to articulate themselves very well. The health workers are not able to understand them well. So we try to identify interpreters who sometimes will have to follow them to be able to give comprehensive health service. And then for refugees who are being admitted at the camp, we organize screening, looking at their nutritional status, checking for other skin conditions and so on before they are allowed to go in. And special COVID vaccination were also provided for them. Now we have to look at the effect of these large numbers on our public health, our health system. Now you realize that with this one, there's an increased demand for health services. Already our health facilities are not well stocked. And in terms of infrastructure, they are inadequate. And so with these extra numbers coming in, there's likely to be crowding at the health facilities, long wait time, and potential delays in accessing health services. And this can frustrate even people, some of them from seeking healthcare, if you consider the fact that they already have a language barrier. Now they come and they have to queue for a long time. Beds for admissions are limited. If you have to admit large numbers now, it becomes difficult, which means that patients on admission have to be discharged prematurely before some are allowed to go in. Again, you look at, we need, in terms of resources for public health interventions like family planning, nutrition, and vaccination. As I mentioned earlier, we are giving these resources. It is a push. Our logistic management for public health commodities generally is based on the push system, which means that we don't determine how much we need at a point in time. National level will push what they think you need based on the population of the various regions and districts. So they will push that to you. And now with this extra population, when we send these resources there, within a very short time, they run short. The danger here is that when we do our administrative coverages, you think you are doing well because the denominator is small. It's constant, but the numerator now has increased. So you see that you think you are doing well, but what is happening is that you're actually missing out some critical people that will likely create problems for the service in future. And then we also think that they need for specialized care for these ones because they are experiencing war. Some have experienced murder of relatives. Some have separated from families. They don't know where they are. And so you go to the camp, you see a child and no parent or a young person, he doesn't know what is happening at home. All this increases the demand for mental health services and also reproductive health services. And some come with chronic conditions like hypertension, diabetes. In the midst of resource limitation, this is a major problem for us. And also we think there is a risk of disease outbreak due to the large cohort of unvaccinated population that that are coming in. And also there are some diseases that may be prevalent in their countries where they are coming from compared to us, that our surveillance system might not be quick enough to pick them. So if we are not lucky to strengthen maybe the event-based surveillance system, there could be public health emergencies there that can cause major problems, spill over to our population. So we look at they also require that with these numbers that are coming in, the workforce capacity will need to grow. Unfortunately, as I projected the first slide, you saw that every year our numbers keep dropping. The other thing is that the average years of experience for staff in our regions is like roughly around 3-4 years, because majority of them come from down south, and then they come because of the current posting systems. They are forced to come here. It's not their preferred destination. So when they do the minimum 3 years period, they are requesting for transfer. So in terms of experience, it is low. In terms of numbers, you have inadequate. And this will lead to a burnout of the few that are already there. And it has an effect on even the quality of care. The quality may be a problem. Of course, language and cultural barriers, they are major issues that we also confronting among the immigrant population. Some have, for some, you cannot talk to if a woman is coming to the clinic, the husband has to follow. So we need to understand those cultural dynamics and win their trust. And finally, there are financial implications because they are been displaced. No health insurance because they are not distant. And the health service will have to procure additional medication to be able to meet their needs. And the public health programs that we have to provide when we are doing seasonal malaria chemotherapy, we need more resources to be able to reach out to all of them. And I talk about the lack of accurate data to track services. And so that can obscure the performance of the service if you don't accurately target to know where they are. And some are in difficult to reach areas that we find it a challenge accessing them. When you look at the effects of these numbers on the refugee-owned population, we're looking at the language barrier as a potential challenge that will limit their access to health services. There is also lack of, they are not familiar with our healthcare system. And so until it is critical, they may not even attempt to come in for the services. And I mentioned the increased needs for mental health services, sexual and reproductive health services in the midst of very limited human and other resources. Of course, you saw you see some pictures of overcrowding and poor sanitation in some of the settlement areas that will produce a fertile ground for the spread of infectious diseases. malnutrition is going to be a major problem. And in particular for this year, where the season has been terribly poor, the farmers those who planted very early, the rain stopped for a very long time and their farms burned. Now, our region already is struggling to address anemia in pregnancy, anemia in children. And so with food insufficiency and with these numbers, we expect to see a potentiation of this particular challenge. And for the host community, the population, the extra population also compete for the same resources. So when the people, they used to go to the hospital, they don't queue for the services and quickly they go. Now when they get there, people are also there. They have to wait because it's first come, first served. And then when it comes to water, they have to go and fetch water, and where the source of water is borehole and so on. They have to go and queue and so on. This is leading to tensions and conflicts with the host communities. And then we've noticed that in Zini community, where the camp is, the refugee camp is, the health facility that is there lacks some of the essential medicines. So when they come to the facility, what is available, the facility will provide the same services for them and the host community. But then whatever is not there, they will get it from the camp. So Ghana Refugee Board has made provision drugs or services for them. So they are able to get their requirement. The host community is not able to get their requirement. And this is straining the relationship between them, because we are giving you a land to settle and you are giving preferential treatment. We are disadvantaged. And there are background bickerings among the indigenous. So in summary, these are some of the potential public health threats that we think that the regions, which is not just Upper West, but the other regions are likely to experience. We're going to probably experience increase in maternal and neonatal deaths and worsening indicators, because if access is reduced, quality is compromised, because the numbers have overwhelmed the health service. Then, more persons are likely to lose their lives. Increase in gender-based violence and outbreaks of vaccine-preventable diseases. As you see, more of them are unvaccinated compared to our own population. And then likely shortage of PPI vaccines and logistics is going to increase the cost of services to them, to these areas, because some have gone to overbank areas. So in a rainy season like this, it's difficult to reach out to them. If you have to do that, you need long periods of travel, pressure on few motorbikes to be able to reach out to them. Water crisis is one of the things that will likely occur, and potential overcrowding in the communities like schools and so on. And then the likelihood of getting the increase in crime and conflict between the communities, the host communities and the settlers, because of competition for resources. And all these have challenges for public health. So we think, essentially we need a resilient health system that will be able to contain this. And remember, the solution is not yet over. There's continuing crisis over there, intermittent attacks, and people will keep on coming in. So if we don't get solutions, our health systems in these regions will be overwhelmed. But the question is, how do we achieve this? I will attempt to just propose, and then during the discussions, we will get more ideas and then the way forward for us as a country. I think there's hello? Okay, so I think there's a need to have a comprehensive preparedness and response plan, especially in the midst of ongoing crisis that will specifically address the needs of these refugees and not compromising the health challenges of the local population. And so protocols for screening, how do we get those coming properly tracked to get them vaccinated and so on. There must be a comprehensive plan to quantify extra resources that might be needed to take care of our baseline population and this extra kind of population. We also think that we need to strengthen the capacity of the health system to be able to respond to this increasing demand. And in this, training of the health staff on trauma-informed care, cultural competencies, and I talk about more human resources. It's a question mark. Where do we get them from? They are rather living. How do we get what deliberate efforts are we going to put in place to attract more staff to these regions to be able to absorb the pressures that we are experiencing and potentially will experience more? There's a need to improve on the healthcare infrastructure with additional health facilities and even equipment that will be able to absorb more of the pressure and possibly get interpreters to ensure effective communication. They need to have proper community engagement with local stakeholders. Because of cultural differences, we need to include them in the design of our health service and the implementation of the health services. You know, we have our CHIPS systems at the community level, and doing these services, we engage community leaders, the community health committees. How do we get their interests represented? You know, so some of the community health committees are being reconstituted to include members of this the migrant community, I mean, their leaders to be part of it, so that they will be able to communicate some of the decisions of the health services to their own members, and also to encourage their participation in health service delivery. There must also be a proper strengthening of the community early warning systems. And here I mean the event-based surveillance system, where we get community volunteers to pick up signals at the community level. And we need to get members among these populations, so that when they are trained properly, if you see maybe 2 deaths within one family, report to us, or children running diarrhea, report. We need to be able to get this early warning system well established in these communities to be able to early detect and report for investigation and prompt action. And we think that there must be a strong collaboration between the health service and then the humanitarian crisis. I mean, in the humanitarian organizations, to ensure a coordinated and comprehensive response to the health needs of the refugees. Yeah, I know in time past, when camps are established, they go and build the health facilities specifically to take care of the refugees. We think that this might be, it will lead to some conflict. And fortunately, I think just today, the UNHCR rep came here, and the plan is to be able to, if whatever resources they are providing in terms of building a health facility, it will be for the whole community to benefit. The health service will be in charge of running that service to get accurate data, rather than leaving that in the hands of partners who do parallel services. This is likely to be more inclusive. In terms of resource mobilization, who brings what, collaboration and partnership is the way I think we need to go. And then they need to implement a robust health information system to be able to track the health status of these districts, so that we'll be able to know whether with this extra population, are we doing well? I mean, what is the performance relative to the service indicators, and also to be able to detect outbreaks and the effectiveness of interventions that we will be rendering to the people in these areas. So, in conclusion, what we're saying is that the crisis in the Sahelian region is a source of extra population flow into the districts in northern Ghana. And this already is now creating a huge capacity problem for the health services in these regions that are already weak. If you look at, in terms of, I mean, we've all read the Ghana Demographic and Health Survey report, and the indicators for these regions already fragile. So with these numbers, the services in these regions are likely to overstretch and will not be able to meet the needs of the host communities as well as their asylum seekers if key interventions and deliberate efforts are not put together to be able to build a health system that can withstand this shock. So we think that there's a urgent need to galvanize strong collaboration between the health service, humanitarian organizations, communities, local government systems, and partners to deal with the crises that are currently taking place, and the threats that the regions in the north are likely to face. So that, in brief, or whatever, I don't know whether I've spoken more than my time. This is what I have to share. These are a few pictures of this. This is the camp, the Zini camp, where the refugees are currently. Some of them are currently located. When we went to assess their situation and to interact with them. So thank you.
Okay, thank you so much, Dr. Damien. Okay. We've quite achieved all that we have through this comprehensive guide, but time is fast spent, and I want us to see how easy things can be, creating this winning and growing, but yes, still educating session. I would like to invite the General Secretary to take charge of the questions and answers, to also receive inputs into this, as well as recommendations into this particular discussion. So, Mr. James Makion-Amoah, kindly, we have 5 minutes for this particular session, so kindly help me in that regard. Yes, sir.
Thank you very much. I think first of all, we'll have to say a big thank you to our presenters for the presentation that they've given to us. We really appreciate it. And just to say that, Dr. Damien, I was in your region some months ago, and I was in Zini. We had a medical screening for the community, and so many of them come in. I really saw the challenge that they are going through, especially with the medical professionals in there. So there's a need for us to do more to help. So to all of us as participants, it's time for our question and answers. Please be brief, go straight to the point, and then if you have a question, please ask the question. If you have a comment, try and make a bit brief so that we can do this in 5 minutes. So I want to start with George. That should be Dr. George Amofa. Can please unmute and start.
Yes, thank you very much, and thank you, colleagues, for this excellent exposé. Just some two quick inputs. One is in terms of the robust strategies going forward. I mean, you talked about communication and other things. That is quite good, but one particular component of communication is the risk communication part. But because from experience in terms of pandemics, epidemics, and other things, that aspect of communication is usually ignored, and I think it has to be properly highlighted. And the communication should be able to also address fake news, misinformation, and other things, because those fuel the tensions in the area. And the last part is that most of the strategies you mentioned, though very, very well articulated, are still scratching the surface, if I want to put it that way. Because if we look at the underlying causes of some of these things, they haven't really been addressed. And so if we wait for things to happen before we address them, and so there's a need for advocacy at the higher level. Prevention is better than cure. Don't anything that will stop the crisis from happening somewhere before it forces people into your country or into your region. It should be part of the strategy. And I think that has to be done. So those war mongers and other things know that there's nothing easy anywhere. And so the consequences of some of these things are enormous. Over. Thank you.
Thank you very much, Dr. Mufa. Please, any other person with a comment or question, you can please raise your hand and speak. Okay, any other comment? If you have you can also type in the chat box if you have a question to us. So, okay, Dr. Gongo, yes, please go ahead.
Everybody, I'm sorry I couldn't join you from the beginning because of my internet problems, challenges. I had some challenges. I want to also add my word to thank the presenters for very brilliant presentation. My question is, what is the regional or district response? Not the health sector alone, but the district assembly and the various MDAs, the region as a whole and the various MDAs. Because this is not only one sector problem. And as in a system, if there's no concerted, integrated approach, the health sector alone cannot do much. And I don't know whether there's a regional approach to that and district approach to addressing the problem. Secondly, the community engagement. I don't know to what extent, because this problem, I can tell you, can take more than a decade. Because since it started many years ago, instead of retreating, it has been expanding towards the coast. And recent events points to that. So therefore, we need to see it as a national issue. We need to see it as a regional issue that must be approached, and not just for health leaders to battle this effort. And it has always been proven that such challenges, we need to engage the communities, the borderline communities very well. Because when they are coming in, they are the first people to know. And if they are the first people to know, if we are able to engage them well, we will be able to find the best strategy to work with them so that they are coming in, we can easily, or we would at least be able to manage it in a smoother way than when we don't know much about it and suddenly they come on board. The last one is a question I want to find out about the security situation, because apparently some friends of mine on 2 occasions, they were going to Upper West or Upper East for a funeral. The first group, they were molested, rolled on the floor, and they were taking their phones and monies. The second one, it was virtually the same. And there was really a serious battle, but they were able to retreat and run back. So I want to know, what is the security situation, and does it indicate that this influx is a contributory factor? And what is the situation for the security of the staff? I think those are areas we need to also look at. Thank you.
Thank you very much. I think this will be the last comment. Dr. Damian, if you have a response, please, you can. Thank you.
Right. So thank you for, these contributions from my two senior men. Yes, I think risk communication has been strongly advocated for. What is the regional and then district response or approach like? I think at the regional level, there's a coordinating body. It's more of, headed by the regional minister with the security chiefs taking place. Their main focus has to do with the security situation. On very few occasions, health and education were invited to take part. And so profiling people who come in, getting signals on the form of security and so on is in place. And we haven't featured frequently in that committee, and it's similar to the district at the district level. The major concern is on the security, and then the health. I think that traditionally we should be able to handle that. When it comes to misinformation, I think when the situation increased, we have support from UNICEF to train community leaders, bring community leaders together. They even supported us to put up community information systems in 2 border districts where they'll be able to use that to broadcast, and then they teach them on signals that they can pick and what constitutes misinformation, where to get accurate source of information. All this engagement have already taken place, but I do think there's a need to sustain this engagement, these trainings, to ensure that we keep on getting the communities getting aware that the situation is a continuum event and it's not a one-day problem. In terms of the general security situation, you recall that 2 years ago, there were reported disappearance and murders of vulnerable security, night watchmen. It seemed to have died down, and then a few months ago, it just emerged again and has since died again. But in terms of attacks and armed robbery, well, I would think that the intra-regional, I don't know about what the highway robberies may still be a challenge, but in time past, like 2020, 2021, it was difficult to travel to some districts like Wa West and other areas without support. So during those periods, people coming to the region on supervision, the regional commander then asked that we should always inform them to provide escort support. But with frequent checks and also community engagement, they were able to fish out some of those miscreants. And so traveling to some of the communities, now armed robbery still takes place, but it's more, less frequent compared to what was happening a few years back. So it's a mixed picture, the killings of the vulnerable has stopped again, but we don't know whether it will re-emerge. And so I'm not the best person to actually give accurate information, but this is my eye view feelings about the security situation in the region. But of course, traveling long distances, what they now do is some of the areas they put borders. So 9 borders. When you get there, you have to stop until a certain point, then they will allow you to pass. And so that is what is currently happening.
Okay, thank you.
Can I make a little comment on that? I think that for UN, the situation in Bofu is quite unstable, and then it's so very fluid because of the challenge that we have of the issues of ethnicity. I mean, that is internal conflict, and then also the spillover that is also part of that. Apart from that, one other thing I did not mention, I'm sure Dr. Damian is aware, but just that maybe he did not mention it because he said he's not too sure of the figures. It was reported by the Ghana Refugee Board and the NADMO that quite a number of refugees from Burkina Faso were found in the communities in Wipe because they have located somebody there that they know who actually invited them to that place. Fine. So they were quite a huge number, almost about 1,000 or so. And then the communities were against them. Apparently, the chief is okay with them, but then the community members had some problem with them. And the overall lordship in that community, that with the traditional lordship, does not agree with them. And so they had to move to somewhere ahead, is it Buno East or so? And quite about 600 of them have moved there, and that place they were having some challenges. So I think the situation is still that a lot of work is being done on that to really understand what really is the issues there, and then also, and because we're told that even where they are living is not good at all. But I mean, this was reported somewhere early August, and then quite a number of the government agencies were there at the UNHCR, this is the conference room. So there's still a challenge there. When we were doing the interagency assessment in the north, we're not allowed to go to some Boku enclave because they thought that the UN did not allow us to go there because they think that those places were so very dangerous. So we still need to do a lot of work, especially in the sub-region, how to stabilize, political and then social conflicts in the region. And then the issue of communication in the crisis, I think is very, very important, as Prof. Dr. Georgia Mofa just said, our senior, because it is one of the major modules that we train them in during the MIST training, minimum initial service package training, for them to be ready. And because I realized that quite a number of people were talking when we had a crisis in Volta region, and it wasn't very helpful. And so we took that very seriously as to for them to understand what really communication is, and then what is communication during crisis. Who should do the communication? What are the levels of what you can report and what you have to leave for the higher levels and all that. So I mean, that was at least done in the regions and the district in which we did the trainings. It was one of the major things and they were all supposed to have an action plan on that too. That's what I'll add to what Dr. Damian said about that. Thank you, and over.
All right, thank you very, very much. All right, so thank you very much. I think Abna, that will be the end of this Q&A session. You can please take over as we conclude today's meeting. Thank you very much.
Okay, thank you. Thank you very much too. As we are bringing this session gradually to an end, having known all that we've lacked and been sufficient of, I would like to invite the Public Relations Officer, Mr. Rabna Dazi, to help her if any other related business in this regard, just some few minutes. Any other related business on engagements? If there's any other related
Yes. Thank you so much, our honorable presenters, scientific committee. Yes, I want to say thank you to you. Our president still has his hand up, and if we can listen to him. Dr. Gongo, please, will you like to share anything with us?
Yes, I want to say that it shouldn't just end here. And my idea is that they have given us a lot of thoughts, and members have also made some significant contributions. And as an association, and the key objective of our association is really to promote public health practice, to help government and other stakeholders work in partnership to ensure that Ghanaians are healthy and that they are prevented from preventable deaths. And for that purpose, I propose that we document what has been provided so far. And because we didn't have enough time for thorough discussion of the issues, we encourage all others who had ideas to contribute to provide them to the Secretariat so that we will come out with a communique which we can provide to key stakeholders to take the matter forward. That's my proposal. Are there any objections?
Yes, Mr. President, we all agree to your proposal. There are no any objection, and thank you so much for sharing with us this wonderful proposal. We will take it up, and hopefully, if you look at the issues, we really have a lot of issues to discuss with regards to the influx of asylum seekers. And so I believe that if my colleagues would agree with me, we would also need another scientific session on this topic to really digest more into details. So I thank Dr. Damien so much, and Dr. Divine, thank you so much. And on AOB, from my side, the AOB is that we'll be having our next scientific session very soon. And we humbly request that our honorable association members should share widely on their platforms. If you look at the knowledge that we've shared this evening, it's so in-depth. And so they should share on widely so that other people can also benefit from this. Our General Secretary, please, do you have any announcement for us?
No, please. Thank you very much for coming. Thank you.
Okay. Thank you so much, Abna, for moderating this event, and it's over from my side. Thank you.
Okay, thank you so much, Madam. Okay, the President will give us his closing remarks, after which we take our final closing prayer.
Okay, thank you very much. I want to use this platform to first thank the presenters for a wonderful job done. And the fact that we've planned this for quite some time, and suddenly we had to call on them last minute. It's unfortunate, but we are very happy that they were able to make it, and it has come on successfully. I will also use the opportunity to thank our senior people who have persistently come in to support. Dr. Mofa, for instance, and Dr. Otupure was also around. I don't know whether he's still around. He had been a member of the association for quite some time. He is based at the School of Public Health in UST. Their interest in this association business is tremendous. I would want to encourage members to try to see how they can project their role in the association. That's our main purpose by joining the organization. And if that is the case, unless we actually bring our ideas to bear on the organization activities, then we are just being members, but we are being passive members. So I want to use this opportunity to thank all of us on this platform who have been able to make it, and to thank the organizers in particular for carrying out a wonderful job. Thank you all.
Okay, thank you so much, Mr. President. The past president of the Ghana Association for Public Health, Professor Amofa, George Amofa. Sir, we will be grateful if you can you close this particular session for us. Professor Amofa. Okay, if Professor Amofa is not around, I would like to re-invite Ms. Wilhelmina Okwabi. Ms. Wilhelmina Okwabi, if you are.
Sorry.
Okay.
Were you inviting me to do something? Sorry.
Yes, please.
Yes, I muted mine.
Okay.
What do you want me to do?
Please, I would like you to help us, give us the final